Good evening and welcome to our webinar. My name is Carson Carpenter. I'm going to be presenting the webinar tonight on protecting your practice of infection and how to make the office safer for both you and your patients. I'd also like to thank our sponsor, Clorox Healthcare, for allowing this webinar to happen. So for many of you, I believe that you may have attended part one. Part one was back in May, and we covered cross-contamination risks in dentistry, surfaces, role in infection transmission. We went through the guidelines, for example, from OSHA, CDC, went over rules and regulations, and basic infection control principles, strategies. And then, of course, we went over some standard precautions, vaccinations, personal protective equipment, and hand hygiene. That was in May, and tonight, we're going to go over a few new things. And really the objectives are, we want to talk about infection risk and principles and strategies. Also cleaning, disinfection, and sterilization. What do they mean? Basic definitions. Sterilizing dental instruments. And that might surprise you because you might think, well, everybody knows how to do that, but I'm going to tell you some stories that will convince you that this could be a big problem and it's something you need to review with your staff, certainly. Environmental surface disinfection, we'll go over that and give some guidelines for products and surface compatibility. And then finally, I will go over cleaning and disinfection best practices. So let's talk about things we can do to stay healthy. I mean, we're all in this for the long haul. Many of us have 10, 20, 30 plus year careers, me included. And the things we're going to talk about here in part one will make it safer for us and for our patients. So clearly there are infectious microorganisms present in our offices, but it's not just us, it's our staff, it's friends, it's family, it's people who we can take them home to, it's our patients. And we're going to talk a little bit about some ideas for an infection control plan. And the things I'm going to talk about tonight really, in my opinion, need to be written down. In other words, you need to have a written infection control plan. For example, OSHA's bloodborne pathogen standard requires a written exposure control plan. CDC guidelines suggest having a written SOP, standard operating procedure for infection control. And some of these will be based on your state dental board, OSHA, CDC guidelines, and best practices. Some of the things I'll talk about aren't specifically required, but are best practices according to organizations like OSAP, of which we are a corporate member. Your program also involves on-the-job training of new staff members and even further training of existing staff members. The fact that you want to be efficient, you need to practice this as a business, and we need to be practical at the same time. So we'll talk about how to develop this. And let's talk about some key pathogens in dentistry. There's a lot of them, of course, that we can't talk about, but we're going to talk about some key things. Viral hepatitis. Now, between 2008 and 18, so an 8-year period, there were 63 healthcare-associated outbreaks reported to the CDC. Hepatitis B, for example. This is statistically, according to the CDC, we've all seen in our office in a 7-day period about one hepatitis B patient. We may not have known it. The patient may not have known it, but they had it. For hepatitis C, remember that 70 to 80% don't even show symptoms, and again, don't even know they have it. And outbreaks of both hepatitis B and C have been reported in dental offices. And what about HIV? I mean, there's 1 million people plus infected in this country. And symptoms often don't show up for 10 years. So again, you saw a couple people last week that had HIV, they didn't know it. Tuberculosis, while not spread bloodborne, it is spread by inhaling droplet nuclei, these 0.4 micron droplets that float through the air for up to 10 hours at a time in your office and can be breathed in. There's two types of TB infection. There's latent, where you're not sick, you're not infectious, you're not spewing out bacteria, spreading the disease. And then there's the actual TB disease itself. And MRSA, we've all heard about MRSA. You hear about MRSA in locker rooms and in schools. It's carried by 2% of the population. It's definitely found on surfaces in the dental office, including your dental office. So to prevent transmission, a couple of things you want to remember. First of all, you want to do everything you can to stay healthy yourself. You want to minimize contact with blood and body fluids. You want to use the safest possible devices and equipment. There's a lot of devices out there to make practicing safer, whether it be needle recappers, scalpel removers, scalpel blade removers, maybe disposable items, instrument washers, ultrasonic cleaners instead of hand washing. And of course, by doing all these things, we're going to limit contamination. So some of the strategies that I use and I suggest and that you should talk about are using standard precautions. Again, treating everybody as if they're infectious, because you just don't really know who has a disease and who doesn't. We get a lot of calls at compliance training partners, and sometimes the call will go like this. We've heard many of these. We have a known HIV patient or hepatitis B patient, whatever it may be, coming in the office today. Should we were thinking of double gloving and autoclaving our instruments twice. Well, our response would be, well, first of all, you don't really have to do that. You just have to follow standard CDC protocol. But what about the 3 patients you had in this week that had hepatitis B or HIV and you didn't know they had it? Are you going to do that for all of them? I mean, just standard precautions for everybody. Engineering controls, again, mechanical devices, anything that can make an office safer. And this is something that your sales rep can certainly help you with. Work practice controls, that just means behaviors, like, for example, washing your hands, environmental disinfection, sterilization and disinfection, and just some common sense things like not eating and drinking in clinical areas, not bending or recapping needles with 2 hands. And personal protective equipment, one of the most important ones, things like mask, gloves, safety eyewear, which should be worn at all times, long sleeve clothing. These are all things that can make the workplace safer. And first of all, I want to state that the dental workplace is a very safe workplace. Studies show that dental personnel are very healthy, very long-lived. In fact, in a lot of ways, I think it's a super safe environment because unlike other areas in our life, we have personal protective equipment available to us at all times in a dental office. So let's talk a little bit now about cleaning, disinfection, and sterilization. And again, you might think that this is a little basic. Why would I need to know about this? I know how to sterilize instruments. But at Compliance Training Partners, this is a call that we get every week, sometimes more than once a week. And I'll tell you about the most recent one. We're a pedo office. We're in, it was a Western state. We just found out we worked on about 50 kids with instruments that weren't sterile. And you say, well, how can that happen? Well, it's very easy. They looked clean. They were wrapped nicely. They hadn't been run in the autoclave. And when systems break down, bad things can happen. And that's a nightmare for that business. It's a nightmare for the patients. Because, of course, in a dental office, obviously, bloodborne pathogens can be present in blood, saliva, body fluids, can be on our surfaces, our equipment, on our instruments, on our skin. Also, it can be spread through contact with mucous membranes, like a splash to the eyes, the nose, the mouth. And take a look at this chart. And by the way, this webinar, the slides are available for some time after the webinar via the Clorox website. And one of the slides I like here, this is really a slide that makes you stop and think. I mean, look at some common bacteria. Bordetella pertussis. It can live on a surface at room temperature for 3 to 5 days. How about E. coli? Hours to months. Enterococcus species, 5 days to 4 months. Streptococcus pyogenes, 3 days to 6.5 months. And what about viruses? Hepatitis B, it could live on your dental unit for up to a week. Hepatitis C, up to 3 weeks. Rhinoviruses, which of course or the cause of the common cold, from 2 hours to 7 days. Noroviruses, which are very contagious, cause vomiting, diarrhea, 8 hours to 7 days. So these things are there, they can survive, and they can make your life miserable. So pathogens can live on these surfaces for long periods of time, and touching these surfaces can recontaminate your clean hands. As I said earlier, hepatitis B and hepatitis C outbreaks have been reported in dental offices. MRSA transmission has been documented in the United Kingdom, with surfaces identified as the potential source. And ultrasonic scaling, which almost all of us have ultrasonic scalers in the office, and other dental treatments can contaminate surfaces and personal protective equipment with streptococcus. So this is an interesting study, bacterial contamination of 11 dental offices and the impact of disinfection. And basically, all these surfaces, doorknobs, phones, keyboards, countertops, the reception area, actually had bacteria. As you can see, there's a list of all coliforms as well as E. coli. After basic disinfection, they weren't able to detect any on the surfaces. So think of other surfaces in your office besides just the obvious ones that are in your operatory. And this is pretty interesting too. Look at this. The dental chair arm, the patient chair arm, cabinet handles, sink faucet handles. All areas that you should think about because we're coming into the cold and flu season. It's starting to get cold up here in Michigan where I am, and buildings are starting to get closed up. And the cold and flu season is on its way. Few basic definitions. When we talk about cleaning, for example, cleaning instruments before autoclaving, we're talking about mechanical removal, organic and inorganic soil, any debris, whether it be cement, bonding agent, whatever it may be. But it's really important to have those instruments clean before you go on to sterilization process. You'll notice here there's protective gloves on. It's being done with brushes. That's the only way to really effectively do it. So that's cleaning. Sanitization, that's not killing of everything. That's just reduction in the number of bacteria on the surface, like sanitizing break room countertops. There's no need to use in a break room or the front desk countertop, you don't need to use your intermediate level disinfectant, but you at least need to reduce the number of bacteria on some of those commonly touched surfaces. And of course, disinfection, now we're up at a higher level. We're talking about inactivation of most pathogenic types of organisms using a chemical agent, like I'm talking about a spray, a wipe. And disinfection, of course, is less lethal than sterilization because it kills most pathogenic organisms, not necessarily all of them. For example, bacteria that form spores. In sterilization, that's where we're talking about killing all life forms. A good review here, Spaulding's classification. Critical items, these penetrate soft tissue. Good examples of that would, of course, be endophiles, scalers, surgical instruments, anything that penetrates soft tissue or bone. And what you need to plan on doing there is sterilization. That's the only accepted technique, sterilization. Semi-critical items, these contact mucous membranes, so things that would touch the inside of the mouth, like impression trays and mouth mirrors, cheek retractors. And although it says sterilization or high-level disinfection is acceptable, you should really be trying to achieve sterilization. And let's face it, patients feel, they assume that things that we put in their mouth are sterile. And non-critical items, these contact intact skin, so skin that isn't torn up, like your dental delivery unit doesn't really go inside the mouth. Of course, it can touch skin. X-ray aprons, pulse oximeters, blood pressure cuffs, things of that nature. There you're looking at a low to intermediate level disinfectant. Something it's not that harsh and it's not going to destroy this stuff. And we'll talk a little bit later about choosing a disinfectant. So let's talk a little bit about sterilization and high-level disinfection. Now, the path that an instrument really takes in your office, obviously it's used in the clinic, so it's used in your office in the operatory. It's then handled. It's handled, repackaged. It's transported typically to the sterilization area. And at that point, it's sterilized and then it's stored. That's really that path, that circle repeating again and again that happens in your office. So where people often get into trouble is handling and transporting them. So first of all, wear personal protective equipment, so especially gloves, and handle these things with care. In other words, make sure that, for example, you're not transporting a syringe with an on-cap needle. In fact, better yet, according to OSHA, sharps or disposable sharps like needles should be removed as close to the point of use as possible. So if you get rid of that needle right there in the room, or that scalpel blade right into the sharps container in the room, you don't have to transport it. That's a great way to prevent exposure, and a great way to, of course, avoid percutaneous injury. For transportation of these instruments down your hallway, remember to use an appropriate container. So we're talking about a container that covers these instruments, not open, but actually covered. And this is going to stop you getting stuck by instruments. Scalers, pretty easy to get stuck by a scaler, but if it's in a closed container, that's not a possibility. Now, when it comes to sterilization, and we're speaking of heat-stable instruments, and let's face it, most everything you can find in a heat-stable version today. Of course, the real choice in most all offices is autoclaving because it's steam, pressure, and temperature. It's economical, it's fast. Dry heat is good. It's good for things where you're worried about corrosion. See a lot of ortho offices, for example, that will use dry heat. But it takes higher temperatures, it takes longer. And for both of these, monitoring needs to be done. Now remember, not too many of us really look at gauges, displays, printouts. I mean, we do a little bit, that's one method. What we do need to look at, and a lot of people just don't pay that much attention to it, is chemical. It says chemical indicators. I'm talking about the indicator that's on the pouch and inside the pouch where you're looking for color change. And in every case that I've dealt with people who've contacted compliance training partners and said they'd worked on patients with non-sterile instruments, this is where they went wrong. Somebody didn't check the color indicator. But see, it's often simple stuff. I'll give you an example in this last case. It was a good office. We're trying to do the right thing, had a busy day. Instruments were put in the autoclave, and of course when they're packaged up, they look nice and clean, they look shiny, the package looks great. They put them in the autoclave. It was a busy day because it was the end of the day. They closed the door, part way. We all see the door in autoclave is part way open when it's in the vent cycle. So the people came in the morning, saw these great looking shiny instruments, the door part way open like the vent cycle, drying cycle had just completed, stocked all the rooms. Nobody looked at the color change. Okay, so I always say look at the color change when you take them out. A second check is look at the color change when you put them in the storage areas, which is typically in the operatories. Third check, that's why I don't believe in opening packages until you're ready to work on the patient. Look for the color change that third time when you open them in front of the patient. And of course, the last indicator that's so important and required to be done every week is biological indicators, where you're actually putting a spore test in that autoclave or dry heat sterilizer. And again, that needs to be done in all your machines weekly. So one of the things I like about a slide like this is it breaks it down so that everybody's doing the same thing. You'd be surprised sometimes how different people in your office can be doing things differently. Let's really start at the top. Protecting yourself. Again, everybody wearing proper personal protective equipment. Mask, gloves, glasses, long sleeve clothing. Pre-soaking. Now, For example, in our office, we would go, typically, we don't need to pre-soak, we go right into the instrument washer. That's great if it's not full or it's not running. If it is, then we put it into the ultrasonic that has an enzymatic solution in it. Again, not to let those instruments dry out. A pre-soaking tub would be acceptable too, just somehow a way to keep things moist so that these things don't dry on there and they can be effectively cleaned. So you've protected yourself, you've soaked and cleaned the instruments, and now, of course, instruments have to be dry before they're packaged. Then they're put in sealed pouches. Again, these pouches need to have an internal and an external indicator on. I'm a real fan of cassettes because, as this says, load the sterilizer and don't overload. It's easy to get in a hurry, or maybe you need a lot of instruments. All of a sudden, you're running short and overpack an autoclave. Then all of a sudden, you're not getting adequate circulation of steam. I'm a real fan of cassettes and racks to hold those cassettes, which kind of forces you to spread those out and have enough room in there. Again, use indicator strips or biological indicators to confirm. Really, it's a simple and inexpensive thing to look at a color change. The color change doesn't tell you it's sterile, but it tells you it was exposed to heat. It's the biological indicator you do once a week that tells you if, in fact, the machine's working. And then, again, store these in a dry area. Make sure that any of these packages that you sterilize have a date on. In our office, we actually put a date on these pouches. Autoclave 1 is one color. Autoclave 2 is another color. Statum 1 is another color. Statum 2 is a fourth color. That way we can look, we can see the date, so we use the instruments in a first in, first out. And by the color, we can tell which autoclave it came from. High-level disinfection, I'm not a real fan of so-called liquid chemical sterilants. Some of the common chemistry in them would be glutaraldehyde, peracetic acid, hydrogen peroxide mixes. But they're dangerous chemicals, so I don't like them because they're dangerous chemicals. You can't confirm sterilization. You can't wrap them. How do you know that it's been in there the 12 hours that you typically need? But when you're doing it, again, personal protective equipment, pre-soak, pre-cleaning, then soaking according to the manufacturer's guidelines for the correct amount of time, rinsing and drying with sterile water, sterile cloths, sterile gloves, because again, this is very technique sensitive. You can see this is not easy to do, and I am not a real fan of it. I'm really a fan of heat sterilization. For heat-sensitive equipment, sometimes there's no choice, although there's not too many things in dentistry anymore. You shouldn't be able to put in an autoclave. But again, these long immersion times are the real problem. So for immediate use sterilization, every now and then there's a need to sterilize something quickly. And keep this in mind, if you're having to do this very often, you probably need more instruments. If you're doing flash, so-called flash sterilization, because the problem is, first of all, if you need that instrument right away, or you have an inadequate low inventory of instruments, you can put it in there unwrapped in a typical gravity display sterilizer and have it ready in 3.5 minutes. Wrapped items, 5.5 minutes. But again, the problem is you don't have packaging on it. It needs to be used immediately. It's rendered non-sterile very quickly. So again, I'm not a real fan of doing this. If you find yourself doing it, reevaluate. Do you need another autoclave? Do you need more instruments? Do you need both? Again, date related, event related. I really like the idea of color coding of again, this is something we got from our dental supplier, color coded with non-toxic ink with the date. That way you know, let's say if you have an autoclave failure and it was from autoclave 1, which is in green writing, you can just pull all those instruments, not having to pull everything in the office. Now, environmental surfaces, this is where we're starting to get into different chemistries that are used. And this is something that again, the idea of today's webinar is to give you to really make you think about what you're doing, to try to have you attempt to get your whole staff on the same page, and to kind of be the guideline for a meeting I'd like to have you hold with your staff in the next couple of weeks. I always say, buy the staff lunch, sit down for an hour, and go over your sterilization and your disinfection process. See where there's weak links. See what protocols are not written that need to be, so everybody's doing it the same way. And one of the things you might talk about is, just which disinfectants are you using. First of all, what's the ideal disinfectant? Well, you want it to be broad spectrum, so it has great antimicrobial activity, like an intermediate level disinfectant. You want it to be fast acting, time is money. You want it to keep the surface wet. One problem I've seen with some wipes is they're just not wet enough. The surface doesn't stay wet. If it needs to be wet for 5 minutes and it's drying out in 2, that's not good. Not affected by environmental factors like blood, the presence of blood on the surface. Surface compatibility, we'll talk about that. You sure don't want it to destroy your expensive equipment. You want it to be the least toxic possible. You don't want it to smell bad. I mean, if it smells really bad, you don't want to use it. It's got to be easy to use, got to be reasonably priced. Persistent antimicrobial activity, in other words, it continues to work even after you put it on. Water soluble is ideal, stable. It's a cleaner too. In other words, you want something that you don't have to pre-clean it first with soap and water, then use it. You want something that is a cleaner and a disinfectant. And of course, non-flammable. So you're always balancing these things. You want it to be fast acting. You want it to be an intermediate level if you're doing these clinical contact surfaces. Clinical contact surfaces being things you actually touch with dirty hands, like grabbing a 3-way syringe, grabbing a light handle. But you also want it to be low residue. You want it to be surface compatible. So here you see the CDC levels of chemical disinfection. And of course, CDC talks about high level. In high levels disinfection, typically the same product, if it's used for more hours, like 12 hours, can be considered a sterilant. Intermediate level and low level. So really, what are the functions here? Well, the functions for high level would be the so-called cold sterilization of heat-sensitive items. Intermediate level, we're talking about surfaces that are going to be contaminated with blood or body fluids, things you're going to touch, like, again, light handles, 3-way syringe, things you're going to be grabbing in an office. In low level, to clean and disinfect surfaces that aren't likely to be contaminated with blood or body fluids. For example, you don't routinely have to spray your intermediate level disinfectant on a dental chair, which will, over time, destroy it. Instead, a low level can be used. And you can see here, high levels are regulated by the FDA. The other 2 are regulated by the Environmental Protection Agency. And again, we mention here where you might use these things. For example, the low level, that's where you'd use on a reception counter, on dental chairs, chairs out in the waiting room, staff work areas. Regarding efficacy, what's the real difference here? A high level disinfectant or a sterilant can kill endospores. It can kill Mycobacterium tuberculosis. It can kill both hydrophilic and lipophilic viruses, fungi, vegetative bacteria. Or intermediate level, which is again what you're going to be using pretty routinely, it can kill TB, hydrophilic, lipophilic viruses, fungi, vegetative bacteria. Or low level, it kills some bacteria, some viruses and fungi, but not TB. TB is kind of a reference norm here for the ability to kill because it's difficult to kill. Types of chemistry, again, I'd mentioned what's used for sterilants, but for intermediate level, you tend to find today improved or activated hydrogen peroxide, quaternary ammonium compounds, and alcohol, called quats, sodium hypochlorite. That's good intermediate level disinfectant, but obviously you can't use it on all your surfaces because it'll destroy them. And it smells pretty bad, not real popular in the office, unless it's one of the new and improved ones that don't smell, that are made for healthcare. One thing that I want you to do is really start to read labels. That's so important. For example, the EPA lists what's called a hospital or healthcare disinfectant. So what we're talking about, if it says in many of your disinfectants, if you look at that label, what that means, if it's a hospital or healthcare disinfectant, is it's able to kill staph and Pseudomonas. And this is generally for professional use, hospitals, clinics, dental offices, for example. And the language on the label will often say for use in healthcare settings. So that means it's a hospital disinfectant. Now, the OSHA bloodborne pathogen standard, it just says use an appropriate disinfectant. And some of the things that are considered appropriate would be those containing sodium hypochlorite, EPA-registered tuberculicides, EPA-registered sterilants, an EPA-registered kill claim against hepatitis B and HIV, and FDA-cleared sterilants and high-level disinfectants. These things would typically say on the bottle words like meets OSHA bloodborne pathogen standard, kills HIV and HBV, tuberculocidal. These would all be things that would be acceptable to OSHA. Again, common chemistry like quats with and without alcohol, bleach, sodium hypochlorite. Some of these new ones, for example, there's Clorox Fusion is pictured here, which is kind of cool because it's sodium hypochlorite, which is very efficacious without the smell. It's what's called a next generation bleach. It's not regular bleach. It's an improved product dramatically, both in smell and efficacy. And then there's improved hydrogen peroxide. Those are some of the new entrants. The old hydrogen peroxide used to be kind of tough on equipment. The new ones are much better. And the old chemistries that we've all used for years, like iodophores and phenolics, those are the basic ones you see. So what about this TB disinfection claim? And you can see I'm spending a lot of time on labels because I want you to be able to make choices, not just leave it to somebody else. So you'll see TB kill claims. So first of all, how's TB transmitted? It's airborne. There's not much evidence that it's transmitted via contaminated surface. It comes from breathing it in. So why is the TB claim important then, if I just said that? Well, here's why. This is right from the CDC. This is a quote. The ability to kill Mycobacterium tuberculosis is used as a benchmark to measure how well a disinfectant can kill germs. Mycobacteria have among the highest levels of resistance of all microorganisms. So in other words, what they're saying is this is a great reference standard because if it can kill this, it's very effective. Now, what's the claim? Mycobacterium bovis is a surrogate organism for chemical disinfecting. So there's currently no EPA-approved test against Mycobacterium tuberculosis. Mycobacterium bovis is the surrogate. So EPA, as I say here in red, the EPA-registered tuberculocidal disinfection claims are not a surrogate for a disinfectant's efficacy against other bacteria, viruses, and fungi. So when you're evaluating disinfectants, look at the product labels for EPA-registered disinfecting claims against pathogens like MRSA, E. coli, bloodborne pathogens, which can commonly be spread via contaminated surfaces. CDC infection control guidelines for dentistry, this is what they recommend. Selection of EPA-registered disinfectants or detergent disinfectants with label claims for use in healthcare settings. So that's the key thing, label claims for use in healthcare settings. So here's another question that I often get, so I put it in this slide. The CDC says I need an intermediate level disinfectant, but why can't I find that classification on the label? Here's why. EPA labeling guidance, and you remember that for intermediate and low-level disinfectants, the governing body is the EPA. Well, EPA labeling guidance doesn't allow for the inclusion of a class of disinfectant. That's really a CDC term. Like, for example, CDC says intermediate level disinfectant. But the description of disinfectant classes, while it can't be put on the label, it might be found in other marketing materials. I know, for example, the Clorox products say that. But look at the label. The EPA regulates microorganism claims on the label. So if you take a look at this label, like here, you'll see things that are the kill claims for that product. And if you look here, I'm going to slide my cursor over here. It says here, this particular product, it says bacteria, 5-minute contact time, Mycobacterium bovis. Remember, it says TB. That's the surrogate organism. So this is, I look at this label, I see that it kills Mycobacterium bovis. I know it is what the CDC would consider an intermediate level disinfectant. Hope that makes sense, because I want you to start looking at the labels. And again, that's why this webinar, these slides are available after the fact, so you can look at this a little closer if you're not getting all the details I'm providing here. So I like this slide because I say, is your disinfectant killing pathogens and surfaces? In other words, what about your expensive equipment? This is just some general cost. You know, dental chairs, $5,000 to $8,000. Dental units, $6,000 to $9,000. Operatories, cabinetry, countertops, and that's probably on the low side, $4,000 to $7,000 per operatory. X-ray equipment, you know, if it's a basic periapical machine, it could be $5,000. It could be up to $150,000 to $200,000 for a cone beam machine or a cat. So this is expensive stuff. And you know, if you take good care of it, if you're not destroying it with the wrong chemistry, this stuff can last for many years. We have, actually, maybe I shouldn't say a name, but I will. We have ADEC units in our office. They're 9 years old. They look like new. You know, we're taking care of them the right way. So how do you know you're doing the right thing? Well, first of all, you want to look at the product labels. I've already talked about that. Talk to your manufacturer's rep. Take a look at your manufacturer's instructions for use on your equipment and see what they say you should use, because you want to be using the right product. You don't want to destroy this valuable equipment. So what about the materials that you use? I mean, you need to actually know what materials are used in your practice's equipment and surface. Then you can evaluate the disinfectant compatibility to make sure you're not using the wrong thing and that you are using the right thing. Again, read cleaning and care guides for the dental units that you have or the materials that you have. This is a good list because you might not realize exactly what some of these things are made of. But you're talking about countertops could be Formica, Corian. Some are stainless steel, sealed stone. Sinks are obviously ceramic, porcelain, stainless steel. Dental upholstery and dental chairs tend to be plastics like ultra leather, naga hide, contain, for example, PVC, ABS, or PET. And of course, dental lights are made of plastics. Dental cabinets are typically laminates. Dental tubing is typically PVC. And your dental delivery units are typically made of a variety of different plastics. So know what materials you have, and then take a look at a label. This is a Clorox label. That's one of the things I really like about the product, is that they talk about what you're compatible with. So you know you're not destroying things. You know you're picking the right thing. So you've figured out what material you have. You take a look and see what the possibilities are with the different disinfectants you have. And then look again for manufacturer's resources. This happens to be information that you find on the Clorox website. It's something I really like. I would really encourage you to maybe even make a copy of something like this and post it. Because, you know, there's always turnover in a dental office. You're going to get new employees. And you don't want to find out that somebody is suddenly using a harsh intermediate level disinfectant and ruining your apron or ruining products that it's just not compatible with. So get everybody on the same page. A lot of this is just about training and getting on the same page. Again, this happens to be from Dentsply. This happens to be for their curing light. Again, manufacturer's instructions for use, proper cleaning. telling you what products to use and what not to. For example, you'll notice the fourth bullet point down here, the third, it says use of alcohol-based disinfectant solutions will void the warranty. That's because it can destroy a product. So again, you're always balancing efficacy, making sure it works, in compatibility. This is a product we use in our office. What do I like about it? It's an intermediate level disinfectant. It's one step, which means you don't have to clean it once with another product and then wipe it again. In fact, with this product, it's wet enough you can do it as a one step. Unless there's a lot of visible debris present, you wipe it once, it stays wet with a 2-minute contact time. So for cleaning and disinfection best practices, again, education and staff training is key. What I'm doing today is really helping you, but these are some guidelines for you. Get your staff on the same page with regular meetings. Go back into your sterilization center and tell them that you want to make sure an accident never happens, that we never have to make that call that we just worked on a dozen patients with non-sterile instruments. Figure out, who's in charge, what role everyone plays. I would appoint what I call a safety compliance coordinator, somebody who's in charge of I like to say OSHA and infection control. A key person, a clinical person, I like to pick a hygienist or an assistant who's organized. And again, provide that training, answer their questions. It's really important to get the questions answered. A lot of staff don't know. You know that statistics show that over 50%, in fact, I think it's actually about 60% of dental assistants in this country are on the job trained. So people need training. So that's part of the purpose of the CDC's guidelines, to help establish policies and procedures. Again, select EPA registered disinfectants or detergent disinfectants with label claims used in healthcare settings. A detergent disinfectant means it's something that can be used to clean as well as to disinfect, so you don't need two separate products. And again, follow manufacturer's instructions. Make sure you read that label. If it says 2 minutes, you need to be doing it for 2 minutes, not 1 minute. Again, get everybody on the same page. OSHA says it's required, and CDC recommends having a written cleaning schedule. So I like something like this so everybody can look and know, when do I clean? What product do I use? For example, in our office, we're using a different product. We're using, of course, a disinfecting wipe that is low level on, for example, reception room countertops, reception room chair handles, or I should say armrest, versus what we're using on clinical contact surfaces like a light handle, a 3-way syringe. So you need to have those things written down. Otherwise, people are not using the right thing. Surface barriers, people ask me about them. I think they're great, but they need to be changed between patients. If they ever tear or there's visible contamination, you still need to disinfect that surface. I think surface barriers are great, but again, have a written protocol for what surface barriers you use. Otherwise, you find some operatories are covering, some are disinfecting. Again, select the right disinfectant by reading the label. And that means reading the instructions on the bottle for how to use it, how long it should be in contact. Don't forget, too, that there's not a perfect product that doesn't leave some residue. So, if you're concerned about surface residue based on reading what the disinfectant will do, don't forget, you can then, after that contact time has been reached, you can wipe down the surfaces with a clean, damp cloth. For example, an operatory countertop, a laminate. If I'm worried that disinfectant could cause harm to it, I would have no problem wiping it afterwards. Again, this is expensive equipment, and you're talking to a dentist who actually practices and has made equipment last for many years by taking good care of it. People often ask, too, there's a little confusion about one-step or two-step products. Many of the disinfectants are one-step products, especially the newer products, meaning that they can actually work they can work very effectively even in the presence of soil. So we're talking about if there's some slight debris there, maybe not visible to you, it can still work. It can still disinfect. So in other words, that will tell you if it's a one-step, like VersaSure, for example. I just mentioned Clorox VersaSure because that's what I use. That it's a one-step product. You wipe it, that basically will disinfect and clean at the same time. Now, if I see visible contamination, we would wipe it with VersaSure to clean it, then wipe it again to let the disinfection time start. A two-step disinfectant will specifically say you have to wipe it once to clean, a second time to disinfect. So obviously, a two-step like the one on the left, it can be a good product, but I prefer one like the one on the right. The one on the right happens to be VersaSure. It's one step. It's a time saver. And you know, that's what it's all about, is turning over those rooms quickly, efficiently, efficaciously. So clinical contact surfaces, that's what we're going to talk about next. These are things that you're actually, you're going to touch. So again, I mentioned things like three-way syringe, light handle. But take a look at this list. This is from the CDC. The CDC says everything on this list could be considered a clinical contact surface. But you know what? Use a lot of common sense here. If you take off your gloves before you grab a countertop or a drawer handle, or you grab a pen or a telephone, then it's not a clinical contact surface anymore, and you don't have to put a intermediate level disinfectant on it. So try to, I always say one of the best things in infection control is just having a couple sets of sterile cotton forceps on every setup. So if you have to grab something, you can grab it with that, or just taking off your gloves, not touching stuff in the operatory. Let's eliminate clinical contact surfaces. So for clinical contact surfaces, again, barrier wraps are a great thing, particularly to turn over an operatory quickly, or in areas that are kind of hard to clean and disinfect. For example, I think light handles can be a little tricky to get up there and get those curves and bends. I would rather cover it. You may decide you want to disinfect it. That's fine. But whatever you do, do it consistently. If you're going to be disinfecting clinical contact surfaces, and obviously there are many that you have to. Again, it should be a detergent-based cleaner. It should be an EPA-registered disinfectant that's hospital grade. So again, it'll say for hospital use or healthcare use, it should have a TB claim, which means it's an intermediate level, and it should have HIV and HBV claims. Always remember, too, these are chemicals. I don't care what anybody says about how safe they are. I like to see you wear masks, gloves, and glasses to protect yourself. Again, high-level disinfectants, we talked about that. There's no need to use a high-level disinfectant in the operatory. It's not designed for surfaces. They're harsh and dangerous chemicals. And they'll destroy your equipment pretty quick. So always follow manufacturers' cleaning and disinfection guidelines. Use manufacturer-recommended products, and wear personal protective equipment. You're going to be doing this for a long time, and I want you to stay healthy. Here's some guidelines. Electronic equipment, if you're concerned about residue, wipe it with a damp cloth. X-ray aprons, they often have that plastic covering. Clean with the detergent. Quats are often recommended. Alcohol can be really hard. It can make that plastic dry, brittle, and crack. And those things are expensive. Digital sensors, again, I'm a real fan of covering those with a barrier, but in addition to covering it with the barrier, you want to then wipe it with a disinfectant, an intermediate level disinfectant. So you're going to be taking a digital sensor, and you're going to be covering it and wiping it with an intermediate level disinfectant. Housekeeping surfaces, we're talking about things that are unlikely to cause cross-contamination problems, things you don't touch, like floors, walls, office areas, unused countertops. And what you want to do here is you want to use detergent-based cleaners. For example, it could be EPA registered low-level disinfectants. Remember that mops and cloths, let your cleaning crew know they need to dry out. You can't just keep them wet day after day, sponges, mops, cloths, or else they'll become a laboratory for the growth of bacteria. They need to dry out. Or you could go to single-use mop heads, disposable ones. Again, these cleaning solutions need to be prepared fresh daily, not used week after week. I'll see offices where you see a mop sitting in a low-level disinfectant, for the whole week. You can't do that. How often do you have to clean walls and blinds and curtains? Only if they're visibly soiled, if they're visibly dusty. So this is just a routine basis, not that often. So a couple of the things I want to talk about here, some key takeaways really. Remember that infections can be transmitted between us, the patients, to our family and friends at home. Bloodborne pathogens are pathogens of concern. We don't know who has them, we don't know who doesn't. And multiple factors can influence this. Cleaning, disinfection, and sterilization, just always remember this stuff can live for months, certainly for weeks. Think about that. Contaminated surfaces can lead to outbreaks of infection in your office. Correct cleaning, disinfection, and sterilization can reduce this. And not only is it the right thing to do, it protects your business, because I want you to eliminate as much liability as you can. We don't need to read about your office in the news. We don't need to have any type of outbreak in your office. We don't need to have any negatives for your patients to focus on. Sterilization, remember that although we're so used to it, everybody has an autoclave in their office. We need to go through these steps with staff on a regular basis, how to use these instruments, how to handle them, transport them to the operatory, how to properly clean them. Go back in that sterilization lab and see what's going on once in a while. Appoint somebody to be in charge. Make sure that instruments are being processed properly, sterilized properly, stored properly. And a simple thing, of course, certainly make sure that you're checking those color indicators. Sterilizing dental instruments, again, so important. Specific protocols I mentioned, they need to be written down. Environmental surfaces, talk about your products. Talk about what products you'd use. Maybe consider new products. How do they smell? What does the label say? Do they destroy your materials that you have in your office? Make sure the things you're using are EPA hospital-grade disinfectants. Do look at that label. Check any available resources for compatibility. Again, I'll be honest, I checked the Clorox website. They've done a lot of work on that, so I can see what will harm my materials and what won't. Best practices involve training and educating staff. That's the only way everybody's going to be on the same page. It's just something we have to do on a regular basis, and obviously with all new employees. Develop protocols, written protocols, things like cleaning schedules, standard operating procedures. Make sure everybody is on the same page and doing the same thing the same way all the time. Now, with that, again, I'd like to thank Clorox for sponsoring this and for all the work they do on these quality products. And what I'd like to do at this point, I would like to take questions. I see a lot of questions coming in, and I'd like to take a few minutes to answer these questions for you. Okay, here we go. First of all, I've got a question here. Someone asked a question about something I didn't actually mention in this webinar, but I asked, their question is this. Is it true that low-speed motors in my hygiene room need to be sterilized? It is. It is. Actually, according to the CDC, anything that is connected to, quote, air or water, any low-speed motor, needs to be sterilized. So I will tell you that in our hygiene operatories, we typically have 3 or 4 motors so that we can rotate them. So we're using not only a sterile nose cone, but we're using actually a sterile motor. Very important to do that. Someone else here said that they have an arterial scanner, and they wanted to know what I suggest that they use to clean the screen after each patient. What I would do is, first of all, I would look at your actually instructions for use for your arterial scanner, and I think you're going to find that they'll recommend something. I'm going to tell you that on scanner screens like that, I'm a real fan of using the Clorox disinfecting wipes because they're low level, and then I'll wipe it afterwards with a moist, just a clean towel moistened with water just to eliminate any residue. Someone asked here too, should all instruments be scrubbed, immersed in cold, sterile water for a length of time before they enter the autoclave? No, you don't need to put them in sterile water. What you need to do is you do need to scrub them so they're clean. You could hand scrub them with personal protective equipment, but I think a better choice is in the ultrasonic, in the instrument washer. Then they simply need to be dried and then packaged, but they don't need to be in sterile water. Sterilization will occur in the autoclave. Do high-speed couplers need to be sterilized as well? At this time, they don't. The high-speed, of course, itself needs to be sterile, but you would be able to use on the coupler the intermediate level disinfectant. Couple other questions here about countertops. Again, what I would do is when you're building an office, or if you have an office that you've purchased, say, a sterilization center, for example, an ADEX sterilization center or a mid-mark sterilization center, actually consult with the manufacturer, because you can't tell just by looking at the material what it is. Ask them for their suggestions, what their instructions for use would be to not destroy this plastic, metal, whatever it may be. Someone asked me here about dental chairs. I will tell you that dental chairs, first of all, I'm a real fan of barriers. I love to put a chair back cover over the chair. It doesn't take long with Naugahyde if you're spraying an intermediate level disinfectant on it to destroy it. The only time that I would suggest using an intermediate level disinfectant on a chair would be if there's visible contamination. For example, blood got splashed on it, okay? And even then, after I did that, I would wipe it with a clean towel with water. For example, a Seafold with water, just to get that material off. It leaves a residue, it dries and cracks the Naugahyde. And the last time I checked, new Naugahyde for a chair is about $2,000. Here, this is a real good question asked by Carrie. Why do instruments need to be dry prior to packaging? That's a great question, Carrie, because a lot of people don't know that. The reason is, and as she said here, they're just going to get wet during sterilization. Here's the problem, though, is when they're wet and you put them in a package, then that package tends to tear, okay, because you're putting them in there. Quickly the moisture is absorbed by the paper. Now you pick it up. It can tear unknown to you. Now, even though it comes out of the sterilizer, and it goes through a drying cycle, it's torn. And when a package is torn, it's no longer sterile. For the same reason, if you're finding that your instruments, in fact, somebody's asking this question right now, if your instruments are being dried before they're packaged, you put them in the autoclave and they're coming out wet. Why is this? This is the question they're asking. Well, it could be that the autoclave is being overpacked. There's not enough air circulation. It could be a malfunction of the drying cycle in the autoclave. It could be that people are getting in a hurry. They're interrupting that drying cycle. Okay, although the instruments are sterile, if the packages are wet, you grab them, they tear, they're no longer sterile. It says here, this is interesting. It said, I temped for a doctor once who would put on a fresh pair of gloves, then wash them with soap, dry with paper towels, and proceed with patient care. Is this not a violation of infection control? Absolutely is. Absolutely is. You just can't wash gloves. They're a single-use item. And you know, it's just not, even if you could, and clearly you can't, it's just a waste of time. It's not worth the time to do that. Just take gloves off. They're not that expensive. If you're going to reach into a drawer, if you're going to grab something, if you're going to grab a phone call, just take off the gloves, throw them away, put on another pair when you're done. This is interesting. Says, I'm using Cava Wipes 1, but since we started using it, we noticed that our x-ray machines, that the plastic base is being damaged with the wipes we are using. I'd highly suggest, I've experienced the same thing, I would highly suggest you go to that Clorox website, take a look. There's some products that are compatible that you won't find that problem. I also see here, it says, does it matter? This is a question I get often. Does it really matter if the autoclave pouch is facing up or down inside the autoclave? You know, it's interesting. There's two schools of thought on that. Most people seem to feel like I do, that the paper should be down or the pouch should be sideways, rather than having the plastic down. Here's why. There's always going to be some moisture in that bag, even though you go through a drying cycle. There's a potential for moisture. What I like about paper down is the moisture can wick through the paper and get out of that bag. I feel that if it's plastic down, it's like a bathtub, okay? That moisture can't diffuse through that plastic like it can paper. So I'm a fan of either paper down or them being on their side, which is another great thing about an autoclave. In the autoclave, using a rack, if you're using cassettes like we are, it automatically puts those cassettes on their side. So, but that's a question I get asked often. What does your staff wipe the lead apron with? Actually, we use the Clorox Disinfecting wipes. The reason we do is they're very kind to plastics like that. I would not use an intermediate level disinfectant on there for the reason it'll destroy it. Now, again, has there been a time when we might have got a splash of blood or saliva on an apron and then use an intermediate level disinfectant on it? Absolutely. But then we would then wipe that spot with water afterwards, okay, so as to not destroy that because it gets very expensive. I have someone here who asked, do you advise using barrier milk, or like a surgical milk or some type of anti-corrosive liquid on surgical forceps? What I would say is if you're running into corrosion problems, absolutely. For example, oftentimes orthodontists for ortho instruments will use something like that. Or on surgical instruments, again, we don't seem to run into too much of a problem in our autoclave. I think it's because the drying cycle works properly. We're not overpacking it. Things are dry. It's when moisture sits on these things that you run into corrosion. But is there anything wrong with using surgical milk? Absolutely not. You might talk to your sales rep about some products that they have. There's a variety of different ones. I will tell you a lot of good questions. I'm sorry for running a little bit over, but there were so many questions. I really appreciate the time tonight and the concern about your patients and about your staff and about your own health. I'll encourage you to go to the Clorox website and the Viva Learning website where you can see the materials I presented tonight. And thank you again for your attention tonight. Good night.